Welcome to this special Gastro Girl podcast. This episode was produced in collaboration with the American College of Gastroenterology's Patient Care Committee. Here's your host, Jacqueline Gollin.
Welcome to a special episode of the Gastro Girl podcast presented in collaboration with the American College of Gastroenterology's Patient Care Committee. Today, we're diving into a topic that's on a lot of people's minds, GLP-1 medications like semaglutide and tirzepatide, and how they impact the gut. These medications have revolutionized the treatment of type 2 diabetes and obesity, but for many patients, they also come with digestive side effects that can be confusing, uncomfortable, and sometimes even a little bit alarming. Now, to help us separate fact from fiction and provide clear, evidence-based insights, we're thrilled to welcome Dr. Katherine Hudson, who's Assistant Professor of Clinical Medicine in the Division of Gastroenterology at LSU School of Medicine in New Orleans. Dr. Hudson, it's so lovely to meet you virtually and to have you on the show today. Thank you for joining us.
It's nice to meet you as well. I'm excited to be on the show. I love your show. I've listened to some of the episodes, a couple that are my favorites. So I'm really excited to be here and talk about this topic, which is one of my favorites. So thank you for having me.
Oh, you're so welcome. And I know you're a busy physician. You've been on some ACG virtual grand rounds, and it's just, we love to have your expertise and insight on this really important topic because we have so many questions that patients have regarding GLP-1 medications that are used for a lot of times for diabetes and weight loss. So let's get right into it. So what are GLP-1 medications and why are they prescribed?
Yeah, so colloquially, they're known as GLP-1s, but they fit into a broader class called incretin mimetics. And that basically means mimicking gut hormones. We have these naturally occurring gut hormones in our body that are released at various times during hunger and satiety and when we're digesting food. And they do different things. So GLP-1s are what we call pleiotropic, which means that they act on all kinds of organs in our body. And so naturally occurring GLP-1s, the ones that are released when we eat fruits and vegetables, they go back to the stomach and tell it to slow down. They go to the pancreas and tell it to release insulin. They tell the liver to do things. They tell the GI tract to do all kinds of things. And so we've created mimics of naturally occurring gut hormones. And that's what these drugs are. So we can give a drug that mimics what the body naturally does and sort of enhance those effects to be able to get the desired outcome, which is improving our blood sugar or treating diseases like obesity.
That's so interesting. You know, most of us hear about semaglutide, tirzepatide. What are the different ones, and what are they supposedly do for us?
Yeah, so there's a handful of drugs that are FDA approved right now for the treatment of diabetes and for the treatment of obesity and for a couple of other indications such as obstructive sleep apnea or cardiovascular disease. These drugs have actually been around since 2005. So, one of the first drugs that was FDA approved for the treatment of diabetes was exenatide. Some people might know it as Byetta or Bydureon. And then we have liraglutide, which some people might know as Saxenda or Victoza. We have semaglutide, which people know as Ozempic or Wegovy. And then we have tirzepatide, which is Mounjaro or Zepbound. So we have a handful of drugs that are FDA approved right now. And we have a whole bunch of new drugs that are coming down the pipeline, which is really exciting. And they're going to be combinations of GLP-1s and then some of the other gut hormones that we know also do some beneficial things. So we also have things like dulaglutide, which is Trulicity, which is only approved for diabetes right now, but is used usually off-label for the treatment of obesity.
Now, these drugs have gained so much media attention and almost like a frenzy, and a lot, you know, it's creating, you know, desire for it, shame around it. We talked a little bit about this before we started. Why do you think that is?
I think that is the result of the drugs being incredibly effective. These drugs work really well. If they didn't work very well, then nobody would talk about them. Because I could tell you about some other FDA approved drugs for obesity that most people have never heard of, don't even know exist, because they work, they're FDA approved for the treatment, but the effect that they have is small. And so these drugs are incredibly effective. And like I mentioned, they've been around for 20 years. So, when people say these drugs are new and we don't know if they're safe, we actually have a lot of data on these drugs that show that they're really safe and they're extremely effective. So people wouldn't be talking about them if they weren't incredibly effective.
Now, there's a whole bunch of different angles we could take with our episode, but today we're really going to focus on the impact and how they affect the digestive system. Because from our standpoint, and probably from yours as a gastroenterologist, you probably get a lot of patients coming to you with GI side effects like
Yes.
constipation, nausea, maybe some vomiting.
Yeah.
Can you take us back a little bit and help us understand exactly how these medications affect the digestive system?
Yeah. So I mentioned that these drugs impact a lot of different organ systems, and one of them is the GI tract. And most people may see this as a problem because it causes side effects, but it's part of how the drugs work. It's not the only way that they work,
Mhm.
but it is part of how they are so effective. So these drugs will cause the stomach to slow down emptying, and that helps with lowering um, uh, the glucose after a meal. They also kind of impact the small intestine and the large intestine as well. So when people are describing problems with constipation, we know it's because the bowels are sort of sleepy when you're on these medicines. When we look at the data, when we look at these trials, what we see is that people report these side effects across the board, but they're more common at the beginning of the drug use, right? So in the first 12 to 14 weeks, patients report these side effects, and as you get closer to about 3 months, the side effects should improve. That's a phenomenon called tachyphylaxis. It means that the side effects sort of get better or go away. And I think when let's say you're trying this drug, you start and in the first month you say, gosh, I have these side effects and this is so miserable, I can't live like this. If you don't stick it out, or if you can't stick it out to about 3 months, then you really probably have shortchanged yourself, because they may go away for you. And some patients, we know it doesn't go away. They stick it out, they've been on it for 6 months or a year, and they say, I just can't stand the constipation, or I just can't stand the low level nausea that won't go away. And these drugs are not for everybody, right? Just like all medications, you have to see what's right for you. And some people, their GI tract is a little bit more sensitive. The volume is turned up on what they feel, so they may have problems with bloating. It may be some abdominal pain. It can also be diarrhea, and I like to explain to my patients, these medicines are going to exaggerate what the natural drug would do in your body, or the natural peptide would do in your body. So it may make your bowels go to sleep and you're constipated for the first 3 or 4 days after your injection. And then at like day 5 or 6, you may have your bowels wake up, and now you have diarrhea, right? And a meal is going to trigger you to have to go to the bathroom, and you have, a lot of bowel movements. So if you can recognize some of those changes in your bowel habits, sometimes you can adjust or treat it symptomatically. I know that one of the important things to consider is this is not a temporary thing, right? We tell most patients, if you're going to take these drugs, plan to need them for the rest of your life. But we know in studies that up to something like 20% of patients can get off of the drug and maintain their weight loss. So not everybody needs them forever, but I tell patients when we're starting the drug, let's plan that you're going to need these forever. And so if we're talking about this as a lifestyle change, this is a chronic disease and we need to make a lifestyle change that's going to last for many, many years. What can you live with as far as side effects? It may be that your side effects are, I used to have 3 bowel movements a day and now I only have 1, and that's tolerable for me. Or it may be that I go a week and I don't have a bowel movement, and that's not a tolerable way to live. So you have to figure out, can I symptomatically treat that? Is this just not tolerable for me? And that's got to be a patient provider discussion.
So when you kind of touched on this, but just so patients have it top of mind. What are some of the common GI side effects that patients may experience?
I think the most common one that everyone's aware of is the nausea and vomiting that can occur. And when patients come back to clinic after starting on the drug, I'll ask them about the symptoms of nausea, vomiting. And I find that patients who are really tuned in, who are really paying attention to how the drug impacts them, they recognize that, well, I overate because I knew I was about to be on the drug, so I wanted to eat this like last meal before I took my medicine. And then I took the injection later in the day, and then I threw up later that night. So if you overfill your stomach while you're on the medicine, even if it's the first day that you inject the medicine, your stomach may go to sleep and that meal may sit in your stomach for 12 hours, 24 hours, or even longer. Actually, in my practice, when we were trying to address some of the issues that I think we're going to talk about later today, this risk of aspiration when you get anesthesia because there may be food still in your stomach, we started looking at, we've asked patients to stop their drug a week ahead of time, and some stopped it 10 days ahead of time, 2 weeks ahead of time. And then we asked them not to eat any food for 8 hours, or they haven't had food in 12 hours or 15 hours. Do they still have food in their stomach, even though they haven't had a bite of food in 12 hours? And the answer is yes. Some people did still have food in their stomach. So you think, I ate this food, it's probably gone after, 4 or 5, 6 hours. On these drugs, it may not. And so that can really cause a lot of nausea and some vomiting. So I always counsel my patients, when you're on this drug, do not overfill your stomach or you may have some trouble. Similarly, if you overfill your stomach before you go to bed, that can be a problem because when you go to sleep, your bowels tend to go to sleep. So now you have the effect of the drug plus you're sleeping. So if you eat a huge meal and then you go right to bed, when you wake up in the morning, your stomach may be full of that food. And then when your body wakes up and your bowels wake up, your stomach recognizes it's full of food and that doesn't seem right. And so then you may have some nausea in the morning. Good luck brushing your teeth, without feeling sick. So I think there are some ways to work with timing of the drug, timing of meals, what kind of meals you're eating. So if you're eating a really heavy meal, let's say you go out to dinner and you have something like a fettuccine alfredo, that may be something that's going to trigger food to stay in your stomach even longer because of the high fat content. That may be something that'll lead to some nausea and vomiting either later that night or the next day. So
Yeah, no, that's a great point. It leads us to our next question is, what are some tips for managing the GI side effects? Now, the drug isn't a miracle panacea be all end all. There has to be some behavioral changes
yeah,
on the part of the patient. And that includes dietary, maybe
yeah,
taking more protein. We don't want to have muscle loss, correct?
right.
We want to make
Yeah.
sure we're getting proper nutrition because we're having most likely reduced calorie intake. So, talk a little bit about some of these tips for managing the side effects and just overall nutrition.
Yeah, that's a great point. I'm glad you brought that up because there's a lot of stigma around obesity, right? And there's a lot of misconception about what the drugs do. When I looking at posts on social media and I see these comments where people say, "Oh, people are just taking these drugs so that they can eat whatever they want and not have to worry about it." That is 100% wrong. And I can tell you, I've seen patients in my clinic who've been started on drugs with other providers. They got the drug and then they didn't do anything to change behavior. And then they come to me and say, I'm on the max dose and this drug isn't working. What can I do? And it's because they really didn't understand the drug, just like bariatric surgery, is a tool that helps people do the lifestyle modification. So, lifestyle modification alone, which means making a calorie deficit, not cutting back necessarily on the amount of food you eat, but cutting back on the number of calories that you eat such that you're taking in less calories than your body needs. That's how weight loss happens. When we ask people to do that, it's not that they don't understand what we're asking them to do, it's that it's very hard to change behavior. Very hard. And the reason why it's so hard is because when you make a calorie deficit, and if you're successful and you lose some weight, now your body changes the gut hormones that we were talking about before to make you hungrier so you will regain the weight. So now you need less calories because you weigh less. and you're hungrier. So it's very hard to maintain weight loss when you do it just with diet and exercise. It can be done. It's just very difficult. And so tools like bariatric surgery and drugs like GLP-1s can help you maintain weight loss, achieve weight loss because it turns down the volume on food noise in your head. So if you can feel less hungry even after you've lost some weight, that's a helpful way to continue the lifestyle modifications. So yes, lifestyle modifications are not just important for actually losing the weight, they're also important to minimize the side effects that may happen. I focus a lot on, instead of asking patients to eat less food or stop eating the foods that you like, I really don't believe that people should stop eating their favorite foods that they love. It's about creating some moderation and having them sometimes instead of every day. But the way that we do that is by eating more fruits and vegetables. And, from some of your other, podcasts, there are people who talk about how fruits and vegetables can be really helpful for things like constipation, right? It can bulk up your stool and help things continue to move. It helps keep water in the bowel, which water helps move things along. It helps with motility and keeping the stool soft. And so I think that sometimes there's a risk that patients will feel less hungry. And so then they'll take in less food in general. And so then they're not getting in as much fruits and vegetables as they would like to. But you have to make that a priority because it's going to help with creating that calorie deficit, and it's going to help with preventing some of the nausea, the vomiting, the constipation. So,
Yeah, like there's great evidence about 2 kiwi fruit a day to help with constipation.
right.
And that could help patients who are on these medications. And I
Yeah,
want to, remind our audience that we're not talking about vanity, taking these drugs for vanity reasons.
right.
There are patients, and you could probably provide better data than I could, the number of patients that are obese, how that impacts their GI health and their overall health. And, especially with things like fatty liver disease,
Yeah.
and all of the GI across most of the GI conditions, having obesity as an issue can really impact their overall health and well-being. And these are the people that we're really talking about.
Yeah.
We're not talking about vanity, Real Housewives ladies that
Yeah.
want to lose 10 pounds.
Yeah, so I think that one of the aspects of stigma that I see related to obesity is this idea that because there's been a shortage of drug, because there's not great access for insurance coverage and the cost is high, there seems to be sort of a Lord of the Flies mentality when it comes to these drugs. And then the way that we sort of shame people to say you shouldn't be taking these drugs is we say, you're using it for vanity and these other
Right.
people need it for health reasons. I think when we talk about vanity, when we talk about aesthetic healthcare, plastic surgery and all of those kind of things, that's really a decision for someone to make with their provider for whatever reasons they want. We have freedom to do that, right? But what we're talking about is the treatment of disease. And it's not just about obesity. We know that obesity puts patients at risk for at least 13 types of cancer. We know that obesity for most can be a precursor to type 2 diabetes. We know that it's related to obstructive sleep apnea, to increased risk of stroke and heart attack and autoimmune diseases. And so, this evening I'm going to another webinar. We're going to talk about fat in the liver and how GLP-1s are now going to have indications for fat in the liver that is inflammatory and causes scarring of the liver and eventually what we call cirrhosis, and can lead to the need for liver transplant or death. And so, what's really incredible about these drugs, we talked about how popular they are and why people are talking about them, is there are so many studies happening right now on GLP-1s for new indications. We have, the flow trial that was just stopped for we think because it was doing so well that they stopped the drugs, they stopped the trial so they could give the drug to everybody else in the trial because it was doing so great. And that's for chronic kidney disease in patients with diabetes. We have indications for both fatty liver, steatotic liver disease, and that is going to be huge because we know that as rates of obesity continue to climb, rates of fat in the liver continue to go up, and that's a big problem. Um, in the world of GI, we also have patients who have inflammatory bowel disease, and this is an autoimmune condition that affects the GI tract. It can be life shortening or life limiting if it's not controlled. And so we're even seeing patients who there may not be an indication for these drugs in inflammatory bowel disease, but what we see is that when we can treat obesity that is co occurring with inflammatory bowel disease, we get better control of the inflammatory bowel disease. And that makes sense because if you have an autoimmune disease, and obesity or adipose tissue or extra fat tissue on your body is inflammatory and it inflames the immune system, when you aggravate the immune system that's attacking your body, then that will lead to worsening of your autoimmune disease. So, I think what we're going to see is indications for potentially Alzheimer's. There's studies on Alzheimer's and GLP-1s, addiction. When you take these drugs, you just don't feel like having a drink anymore. There's going to be so many good uses for these drugs that will have indications, and then others that may not have indications, but we know that they help with the treatment of the comorbidities. So it's really exciting to see what's happening in the world of GLP-1s right now.
And Dr. Hudson, I'm really appreciative of our conversation because this often doesn't get talked about to this depth and breadth. It's usually just the end goal, which is weight loss. And there's really so much more. And patients who may be considering, they come to you, they're GI patients, and they may have comorbidity with obesity. And they have where they can have IBD or liver disease or even kidney disease. How do you counsel them in their determining what the choice of weight loss? Like, was it a drug? Is it surgery? Like, what are the options and how do you counsel them? If someone they may only know what they hear in the media and they're coming to you and like, what should I do? I need to do something because I'm at risk for X, Y, and Z.
Yeah. I think that just from my own personal experience treating patients with cirrhosis of the liver, with inflammatory bowel disease, co-occurring with obesity, I had one patient, as an example, who had cirrhosis of the liver. And the things that drive cirrhosis of the liver can be alcohol use, which this patient had stopped drinking, obesity, which we talked about, fatty liver, and metabolic dysfunction like diabetes, which this patient had. And so, this patient that I was seeing had what we call decompensated cirrhosis, meaning that the cirrhosis was so far advanced that now it was causing some of the problems that we see at the end stages of cirrhosis. And the patient, when I talked to the patient, I said, look, you're at the end stages. So we're going to be honest about what is life expectancy? What is your quality right now? And I said, what are the things that we could do right now that would improve your quality of life? Because part of the end stages of cirrhosis are confusion, this thing called hepatic encephalopathy. And this patient was having a hard time taking care of themselves at home because of the obesity, because of difficulty ambulating, needing a cane, being confused and having to take certain medicines, and lived alone. And so I said, what could I do for you right now that would improve your quality? And I was really surprised. This was many years ago. I was really surprised to hear the patient say, I'd like to treat my obesity. I would like to weigh less so that I could get around my house and take care of myself. And I said, okay, it seems like that's the least of your problems right now, right? If we're thinking like, oh, he just wants to look better, or whatever, she just wants to do. So I said, okay, I'm fine with that because you also have diabetes and I can get coverage for medicine, right? So I put the patient on one of the GLP-1s that we had access to, a very low dose just for diabetes, not even the obesity doses, just the diabetes doses. And one of even the less effective ones for weight loss. And within 6 months, the diabetes was in remission. The patient had lost 30 pounds. He was no longer having hepatic encephalopathy and no longer needing paracentesis, which is where we remove fluid from the belly that has built up because of the cirrhosis. And so technically, this patient went from decompensated cirrhosis, end stage cirrhosis, to compensated cirrhosis, no longer needed a cane, was able to start working again.
Wow.
And I actually see this patient out and about when I go out to the grocery store, and the patient always says hi to me and says, "You changed my life." This was years ago. And we know that end stage cirrhosis is really, you're at the end of your life. This just saying, let's treat the obesity so I can walk around better, changed everything else. And I think that was a really eye-opening moment for me, where maybe another provider would have responded to that patient and said, "You don't need to treat your obesity. Like, that's the least of your worries. We're not going to do that." But we did it because I thought this is what he's asking for. And it made all the difference. And I am such a believer now that you don't need to have an indication even to do it, because obesity impacts other diseases. It impacts everything. So to do it is not, it's not about vanity. It is about improving health and increasing length of life.
Did you write an abstract about this? Because that or a case report, I think that is worthy of some published publication. I mean, that's amazing.
Yeah, what's really exciting is the American College of Gastro has allowed me to start a task force on obesity and metabolic dysfunction, and we're pulling together some of the best minds in the field, including hepatology and inflammatory bowel disease, so that we can talk about cases like this and basically provide some guidance to other gastroenterologists who maybe haven't yet recognized the value of treating patients. And we know that there's value in it, but it's complicated, right? Because we don't have access to the drugs for everybody. We have to be creative. The prior authorizations are a mess. The drugs are really expensive. So it's a lot of work to use these drugs. But we're going to find ways to support other physicians to be able to do it. And those kind of cases that I just described are exactly what we need to be talking about, because those are the real life cases where we see the value of these drugs.
Well, and also patients listening to this episode and other webinars, and they hear it, they're like, "Oh my God, that's like me or my husband or my grandfather. Like,
Right.
let's talk to the doctor about this and see if it could help." I mean, that's huge.
Yeah.
Now, my next question is, because of the effectiveness of these drugs, and then people read about the media. Oh, there's the side effect. There's been gut health companies
Yeah.
claiming all this. You don't have to take an injection. You can take this pill or mix up this drink, or
Yeah.
God knows what else that they can do, claiming to work on those hormones.
Right.
Can you give us some insight? If I was a patient
Sure.
and I was coming to you and say, "Hey, Dr. Hudson, why do I have to take this shot if I can just take this smoothie or pop this supplement?"
Yeah. I will say that the diet industry, which has now morphed into the wellness industry, which is all kind of the same thing, they're looking to sell you something that is not the GLP-1 itself, right? So I've been seeing advertisements for, it looked like gummy bears that you take
Yes.
for the constipation of from
Yes,
GLP-1s.
everything.
And like, if taking something makes you feel better, that's fine. Of course, always beware of what these supplements have in them. They may not be regulated. We don't, as a gastroenterologist, obviously, we see patients who have liver failure from supplements that they're taking something, they don't know what's in it, and it causes liver failure, and that's a problem. So you always have to be careful. But I think the proof is in the pudding when it comes to GLP-1s. And so, if you're taking a GLP-1, how incredibly effective it can be versus some supplement that is just as good as a GLP-1. And I think people realize, like, it's not. And so maybe the public is buying it once and then realizing this isn't working because their friend is on it, and they're like, well, this person lost all this weight and is off their blood pressure medicines, and I want that. And I think I don't blame people for trying. I do blame the diet industry for trying to trick people, but the best way to kind of decipher what is real and what is not real is, if someone is telling you they have the secret drug or supplement, so you don't have to get the real thing, and then they want to sell it to you on the website, that's a problem. If you can find providers who are selling you the the education and the accountability for the lifestyle modification, that's different. But if they're selling you the supplements or some alternative to the drug or something that's going to cure all your side effects, that's probably not real. And I think the best way to figure out what is real and what's not real is to talk to your doctor about it. Now, I will also put out this disclaimer, and I'm not trying to sort of justify some of the bad behavior that happens with physicians and providers out there, because I think that physicians are overwhelmed. The rush of GLP-1s, which, like we said, is an incredibly effective and very popular thing right now, drug. Um, Physicians are overwhelmed. It's a lot of information. It's a lot of research that's happening. It's a lot to keep up with. Getting access to these drugs requires additional clinical support. You need clinic staff who can sit on the phone for hours with insurance companies and fight with them to try to get coverage. You have to document exactly what each individual insurance company wants you to document in order to meet the criteria. So I think when some patients are going to their physician and saying, "Hey, I want to treat my obesity. I think this will help my health," and then the provider kind of pushes back and says, "Yeah, I don't think we should do that right now, or I don't think we need this. We need to focus on something else." Part of it is that they feel like they don't have the support to help you, right? Because in my clinic, I'm lucky that my practice is such that I get to spend 1 hour with each patient. So it's not just about prescribing the drug. I actually do the counseling myself because my patients usually don't have access to a dietitian. That coverage from insurance is just not there, right? So I sit with the patient for an hour, and I'm lucky that I have that time to do that. Most primary care doctors do not have the time to do it. They feel like they don't have the support to be able to prescribe the drugs and to provide the lifestyle modification counseling. So, you know, I don't want to say like, well, that's not a good provider for you. See if you can get a referral to someone else. Try a couple of other providers who may have the time or the willingness to help you. It doesn't mean that that provider is not a good provider. It just means that we're still at a stage in the world of obesity medicine where we don't compensate for me to sit there for an hour. That's not well compensated, right? And the support is just not there financially. So it's challenging.
Yeah, it sounds like it is. Now, for those patients who may be thinking about, they want to maybe learn more about GLP-1s and if it's right for them, like what sort of questions, what should they know before starting? What kind of questions should they ask their provider? I know there's been talk about underlying stomach motility issues. There
Yeah.
could be, early signs of gastroparesis or just delayed gastric emptying, and then they're put on a GLP without knowing that. Like, what are
Yeah.
some of the things that patients should be aware of and asking about these?
So the first thing I would say before even considering starting a GLP-1 is to talk to your provider about what are the goals here, right? Sometimes patients will come to my clinic and they'll say, what weight should I be? Or what should my BMI be? Like, what's my ideal weight? And I will tell them, I don't know. I mean, I can tell you what the chart says, but those are averages. They're not really specific to your health and your comorbidities. The ADA gives recommendations on if you have obesity and PCOS, you should try to get this percentage of weight loss because that's most likely to help with your symptoms. And they have that for each type of comorbidity. And so you can sit there with your provider and kind of look through that guideline and say, I have obesity plus these three comorbidities. What is the recommendation based on the data as to how much weight I should lose? But as far as like what your weight should be or how you want to like, that is really none of my business, how you want to look. But I think the more important question is, what are your health goals? Do you want to get off your blood pressure medicines? Is it that you have pre-diabetes and you want to put that into remission so you never get to full-blown diabetes requiring insulin or whatever? And I think that's the conversation that you start with is what are those goals? The second thing to consider is what you mentioned, which is, am I even a candidate for these drugs? Because, there is a black box warning for GLP-1s for medullary thyroid cancer or thyroid cancers that if you have a family history of thyroid cancer, you can't take the drug. And that is based on the research that they did in rodent models. So rats develop thyroid tumors. And so there's this concern that humans could develop thyroid cancer. Now, when you look at the data, it's pretty mixed. There's not really clear evidence that it does cause thyroid cancer, but we can't say that it doesn't. We still cannot say that it doesn't. And so if you have any family history of thyroid cancer, medullary thyroid cancer, then don't do it. And I've had a patient who came who had a family history of papillary thyroid cancer. They said, well, it's not medullary thyroid cancer. I mean, really, it's provider to provider, but I said, I'm not comfortable doing it. Somebody else might be comfortable doing it, but I'm not. The other thing that you have to consider is if you've ever had pancreatitis. So the data does not support that these drugs increase your risk of pancreatitis. However, that risk was out there initially. There are still ongoing studies. There have been a few studies recently that came out that showed it really doesn't support that. However, when you lose weight from any treatment, whether it's surgery, just lifestyle modification alone, or medicine, you're at increased risk of developing gallstones. And that can certainly put you at increased risk of pancreatitis because a gallstone can get stuck in the bile duct and cause pancreatitis. So if you've ever had pancreatitis for either from gallstones or from just what we call idiopathic, we don't know why, or it was a drug, maybe a GLP-1, you can never take it because pancreatitis can be deadly. So we don't play around with that. So your provider should not be giving it to you if you've ever had pancreatitis. And then the issue about gastric emptying. So the data, randomized control trials on whether or not the stomach will go back to normal after you stop the drug, or does it stay in that condition of not emptying? It does not stay in that condition. So while you're taking the drug, your stomach will not empty well, especially in those first 3 months of taking the drug. But when you stop the medicine, it should go back to normal. Now, something else to note about this is the drug has a really long half-life. All of them have a really long half-life. Liraglutide, which is the daily injectable, has a shorter half-life. But semaglutide, tirzepatide, some of these others have really long half-lives. Um, Semaglutide, to clear 99% of the drug out of your body, you need 9 weeks. So if you said, well, I took the drug and then I stopped it and now I'm still having nausea and vomiting and it's been 2 weeks, yeah, because the drug is definitely still in your system. And I think everybody's different and we don't know when the gastric emptying comes back online. I think it just depends on how much the drug affected you, I think. The other issue is that people can have delayed gastric emptying at baseline, and it was never that bad. And so they never complained about it, or they didn't notice it, or they didn't realize it. And then they start the drug and it makes it worse. So I told you about how we looked at patients who came to endoscopy who had been on the drug. We asked them to hold the drug, and then we looked to see what was in their stomach, even after they'd held the drug, even after they had not had anything to eat for hours and hours, and they still had food in their stomach. 6 of those patients who had food in their stomach after, being off the drug and being NPO, 5 of them had diabetes. And so it's probably that patients who have a propensity for delayed gastric emptying, like patients who have diabetes, they take the drug, they're going to have even more delayed gastric emptying. So if you don't have a problem with it to start with, it's probably fine. So I wouldn't worry about that, but it could also be that you had some delayed gastric emptying to start. So unless you check a gastric emptying study before starting the drug, it would be hard to say that after the drug stopped that it was caused by that because we see people with gastric emptying problems all the time who don't have diabetes, and we don't know why they have that problem. And it takes a while before they realize that's what's going on.
Thank you for that. Now, but before, I know we're running out of time, but I just want to get some quick tips for patients who may be on these drugs already, and they want to know how to manage GI side effects. Do you have some quick tips for managing GI side effects, and then red flags? When should they seek medical attention?
Okay, so I've talked with other providers about this. is it okay to prescribe antiemetics or anti-nausea medicine for patients on these drugs, right? Because the number one complaint is going to be nausea and vomiting. And I think it's appropriate to prescribe anti-nausea medicine in the beginning or whenever you're increasing the dose of the drug. So every month you may go up on the dose. That may be a time when you're having more nausea. So if that anti-nausea drug helps you get through those hard stages at the beginning, I think it's appropriate. If you are needing anti-nausea drugs every day, multiple times a day, for months, this drug is not for you. And some of the tips that I give patients are, eat meals that are smaller. If you're having a lot of nausea, do something like eat a handful of like cold blueberries right out of the fridge. Do something really light and cool, not anything heavy or fatty, and see if that makes things better. If you can make some of those small adjustments to your eating habits, then your symptoms should get better. If they don't, if you end up in the emergency room vomiting, if you end up in the emergency room dehydrated, or having some kidney injury from dehydration, that's when you really need to consider, is this drug right for you? And I have seen where rapid titration, up titration of the drug, where a patient may go to a Medi Spa and the provider there just gives them the highest dose, or they go up way too fast, like every 2 weeks they're going up on the dose instead of going the whole month. I think that's when patients get into trouble with excessive vomiting. And if you ask the drug companies, they want you to be on the highest dose possible. I think that patients should be on the highest dose that they can tolerate that's having an effect for them. So if being on 0.5 of semaglutide, that's nowhere near the highest dose, is getting you the effect that you want and you're tolerating it, then that's all you need. You don't have to go to the 1 or the 1.7 or the 2.4. Like I always say, you don't have to be blasted in the face with these drugs to get the effect. So I think it's about having a conversation with your provider, having a good provider who is going to interact with you and come up with solutions, whether that's lifestyle modifications or dose adjustment. I think that's the key. So my tip is have really good communication with your provider, a provider who you've picked who is willing to work with you. Make the lifestyle modifications that are being recommended to you, which is smaller meals, don't eat late at night, don't eat heavy foods when you're having a lot of symptoms. Maybe even track your symptoms, track what you're eating and track your symptoms, and see if there are certain foods that are making things worse. As it relates to some of the diarrhea, constipation, I think it's sort of the same. You've got to track your symptoms and see, yes, I have a lot of constipation, but when I get in at least one big veggie salad or something every day, I end up having a bowel movement once a day, and that fixes the problem. Or I know towards the end of the week, I'm going to get all this diarrhea, so I'm not going to eat the heavy foods, or, I'm going to take one Imodium or something like that. So treat to symptoms, but also use those lifestyle modification techniques to help. When you're making a calorie deficit, it is essential to eat enough protein, because we do know that, the research has shown that it's not the drug itself that's breaking down muscle, it's the weight loss from the drug that's breaking down muscles. So when you make a calorie deficit, you have to eat enough protein, and you need to do some kind of resistance training to maintain that muscle mass. If you don't, you will lose muscle mass and you'll lose bone density. And that's especially problematic for women who are a little bit older in age. So that is essential. And if you're doing that, then you're losing weight the right way. You're not going too fast. Then things will go better in general. So make sure you're keeping that in mind when you're making those calorie deficits.
Yeah. And for patients listening, if you're able to work with a dietitian, at least in the initial stages, to get some sort of guidance on what your caloric needs, nutrition needs may be, that would be really helpful. And I also wanted to point out, there are some great dietitians out there like Beth Rosen, who really focuses on a healthy weight at every size. It goes back to what you were saying, how it's not about what weight should you be. You could be tiny and have really bad markers for your blood work that show you're at risk for A, B, and C, when someone could be way more and be in much better health. So I wanted to just point that out because we're very sensitive about that when we talk about weight loss and dieting and things like that. And the final question, because this is so important, you touched on it a little bit. If the patient is on these GLP-1 medications and they have a surgery coming up, a colonoscopy procedure, what do they need to know and what should they discuss with their provider?
Yes, I'm glad you brought that up because that is a really important point, and patients are probably the best ones to advocate for themselves. If you are on these drugs, if you're having the side effects, but now we've told you they are going to delay gastric emptying, which means that there may be food in your stomach, even if you've done everything they asked you to do. So even if you held the weekly dosed drug for 1 week and the daily dose drug for 1 day, there still may be food in your stomach, even if you haven't had a bite of food in 12 hours. So you want to tell the anesthesia doctor who's going to do your sedation and the doctor who's going to be doing your surgery, because depending on the reason why you're going to have anesthesia, if you're having, let's say, a GI surgery, they want to make sure that your GI tract is empty. They may ask you to hold the drug for 2 weeks, or they may ask you to hold it for a month. If you're having a colonoscopy, we know that this can sort of cause problems with prepping. So you take the prep, it's supposed to clean you out. But if you're on a GLP-1, there may be some problems there. You may not be totally cleaned out. And so you want to tell your gastroenterologist, you want to tell your surgeon, or whoever's going to be doing this procedure that you're on a GLP-1 in case they want you to hold it longer, do an extra day of clear liquids or something like that, just to make sure that you're totally optimized and to reduce that risk of possibly vomiting up food from your stomach during the procedure when you're getting anesthesia.
Well, Dr. Hudson, we're out of time, and we didn't even get into, you're writing this amazing book, which talks about the compound. Can you tell us a little bit about that? And we definitely want to have you back on the show once your book is out to have you talk about this. Give us a little teaser about your book.
I would love to come back and talk about it. I'm working on a book to talk about how the compounding phenomenon during the shortage of GLP-1s has really impacted the stigma on patients with obesity, because we know that stigma is really one of the biggest barriers to getting comprehensive obesity care for our patients. It's one of the biggest barriers to getting coverage for these drugs and for bariatric surgery. And so the compounding that came in during the time of the shortage, which is now at an end legally, just really kind of unearthed these elements of stigma that we've never seen before with obesity. And so it's such an interesting time to be practicing obesity medicine. And so I'm working on that book, and hopefully I can come back and talk about it when we get a little bit closer.
Oh, we'd love to we'd love to have you back to talk about this. It's such an interesting topic. And who knows, by the time your book is out, do you know a date, an estimate?
No. I mean, I would say definitely not this year, so maybe sometime next year. But my gosh, like you're saying, things are happening so rapidly.
Yeah, so fast.
There's so much happening.
Yeah.
So we'll see.
Well, this is amazing. Thank you so much, Dr. Hudson, for sharing your expertise and helping us better understand how these GLP-1 medications affect the gut. And for anyone using or considering these medications, we hope today's episode helped answer some of your questions and offered reassurance that you're not alone in navigating these side effects and questions. And remember, every patient's experience is unique. So if you're struggling with GI symptoms or have concerns about how these medications are affecting your digestive health, don't hesitate. In fact, we encourage you to definitely talk to your healthcare provider. And for more evidence-based digestive health tips and resources, visit gastrogirl.com or the ACG at gi.org, and check out the Ask Gastro Girl app. It's in the Google Play and App Store, as well as on our website. And it's your personal, trusted companion for gut health guidance. Thanks for listening. Don't forget to like, subscribe, and share this episode. And until next time, thank you very much.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.